It's very deadly to let someone withdraw off of alcohol, more deadly than heroin. Heroin's uncomfortable, but not as deadly as alcohol.
All right, welcome back to The Weaponized Body, where we cut through the noise of movement, metabolism, and mindset. In today's guest, we have a pioneer in the field that's rapidly evolving, testosterone optimization. So you've seen him in Generation Iron, read about him in Men's Health, and you've heard him called the Anabolic Doc. I'm thrilled to welcome Dr. Thomas O'Connor, founder of Testosterology. And joining us today as well is Andrew DeCaro, who is a pharmaceutical industry expert. He's also the director of affiliate and global relations with the Testosterology movement. So these guys are leading the charge when it comes to doing hormone therapy correctly. So I want to welcome both you gentlemen to the Weaponized Body podcast. So yeah, of course. So I'm super stoked for this conversation. So what I'd love to do is just start with a short backstory. We don't have to get into looking way back, but Dr. O'Connor, I just wanted to know what inspired you to create this testosteronology movement?
Oh, thank you, doctor. So I'm an internal medicine doctor, right? I'm 60. I've been on testosterone and some
look at those guns
since I'm 23 years old. And I went to med school, to be an internal medicine, really to be a cardiologist, way back in the 80s and 90s. I was on some steroids a little bit. I was in my 20s. I did wait to about 23. Back in the day, we did that crazy stuff,
Sure.
But I did do it. And I was, we knew back in the 80s that the wrestlers were dying. I think the wrestlers were dying first. And not then the bodybuilders into the 90s and stuff. And here we are. So then I was like, I love this. I just want to be living and sleeping this and pooping this. So long story short, I kind of dropped what I was doing in my 20s. I have an architecture degree. Of course, I'm ADD and I'm on the spectrum, which helps with the photographic memory. And I was just a lifter. So I was like so gung-ho. I was everything I could do about physiology and science. So I got a master's degree in exercise physiology, realized that wasn't going to be enough for me. So I went back to med school at 30 to Syracuse University, pre-med, post-bac pre-med. And then you have to get into med school, then resident. And so it took me to 37 years old to get in and out of med school.
Never too late.
Residency training. And then as I went to med school, remember, I'm on med school and residency. I'm on testosterone and even some steroids because I'm not going to bullshit you guys. Be careful. But I'm a power lifter, right? I don't bodybuilding really wasn't my MO. It was more like I like to bench, squat, and I love it, man. And I just want to hang out with dudes who just want to be strong. And then, after you work out, have your protein shake and just go home and just, with your kids and I became a real doctor in internal medicine. By day, I was a doctor. I even had ascots and ties and stuff I used to wear. I was trying to be civilized in the Northeast. And then by night, I would go to hardcore. I was a flip guy. I mean, it was like a two different person. And then over time, that quickly evolved where men started coming to me from just underground, just like that are on steroids. They're concerned for their heart. They may have had a heart problem already, or they don't feel good. They have some depression. They're on and off. I mean, sexual issues. I mean, not really the cosmetic gynecomastia and stuff. They came to me because I was an internal medicine doctor and they were shit scared. And again, they had medical problems with the kidney, the heart. So I started off with the biggest, baddest guys in the world on a lot of steroids. The tier, I didn't start off with TRT. I started off with professional bodybuilders and strongmen from the top because I was with them and it was just word underground. I started writing for some of the magazines. I ended up writing as the anabolic doc for muscular development, and I just skyrocketed. That's the story. But I was always a doctor of primary care. So I had up until about maybe 8 years ago, I had two lives. I had primary care. I take care of little old ladies.
Mhm.
I'm on staff at nursing homes. I go to hospitals. I didn't think I could have a business of anabolic doc or testosteronology. Then, Brian, going through years, and this is my 20th year of
Mhm.
residency, my 25th year or something in med school and training underneath. It's like 30 years, but it's like I've never looked back. And as I became a internal medicine traditional doctor, I realized that men on steroids are widely discriminated on. Internal medicine doctors don't know shit. And I'm
Yeah.
saying
Well,
that from an academic standpoint. Endocrinologists, it's an embarrassment when you don't know what an anadrol is.
right. That what is the biggest misconception do you think, doc, that patients and even doctors still have when it comes to testosterone?
And I'm aggressive that way. And again, to my peers, I do this. Yeah, I do it for shock.
Mhm.
I'm a big social media guy, and you know what? It works for me. But I'm respectful to those guys because they should know better. If you're an endocrinology doctor, you can't know everything. So take diabetes. I don't know diabetes like they do. With a
Mhm.
PCSK9, with the GLPs, with the sodium glucose co-trip, how can you? They're diabetic guys. You can't do thyroid, diabetes, osteoporosis, and then hey, give me a patient on steroids to recover that guy with fertility. Hey, give me a testosterone guy. Let me look at his red blood cells. There's no way. There's no way. So I realized that the misconception is that it's easy. Just take testosterone and just dial up an endocrinology doctor or a urologist. Urology doctors are awesome. They're surgeons.
Mhm.
People don't know there's medicine versus surgery. Then you have ophthalmology and dermatology and psychiatry. You're either a medical doctor or a surgical doctor. That's it. Again, no one knows this unless you're in the field of medicine. And of course, there's some intermediate. I'm being basic here. You're a medical doctor, you're not a surgical doctor. I don't do surgery. Urologists in the turn of the century, from the first sentence from 1900s into the 1950s, they were men's health because we didn't know anything. It was then as it grows, there's 7 doctors for the heart now. There's multiple types of surgeons. Everything's subspecialized. So I
Mhm.
saw testosterone and I was like, it's really the best doctor and healthcare provider that's going to take care and specialize in men and women on androgens from steroids to testosterone is going to be internal medicine trained primary care that
Mhm.
understands ABCDs because it's not just endocrinology, it affects the heart. So it's
Everything.
cardiology. It
No
affects
doubt.
the blood cells. So it's
Absolutely.
hematology. It's a little psychiatric. So it's a little
Sure.
you better know depression and anxiety. That's primary care and psychiatric medicine. It's the last thing it is just endocrinology. And it certainly has nothing to do with urology unless your prostate has a problem. When I deal with men that have prostate issues, I, of course, appropriately work with a great urologist, and I don't touch that. I'm a
Yeah.
coordinator. So the misconception is it's easy to give testosterone. Don't worry about it. And the
Right.
misconception is I'm going to be careful here. I created this, right? Single handedly. However, I've been around for a long time, and there's really no guy in the world that has benched over 500, done steroids, and been an academic internal medicine board certified doctor.
He's right.
There's just no one. We should do a contest. You have to be board certified internal medicine, academic, publish articles, and bench 500, and you can compete in my little group. How many
Yeah.
guys are out there? I'm not saying chiropractors. You guys are special and
No,
good.
no, it's
I'm
all
not
good. That's
saying,
why I love you.
and again, I don't. A lot of people don't like me, but this is a New York attitude, and I'm not. I'm not here for bullshit. So in the
Oh, I
end,
love it.
the misconception is, doctor, that it's easy to do, and you could cookie cut it. And the anti-aging guys, we're done with anti-aging. Testosterone doesn't anti-age. Matter of fact, if you do testosterone, you're at a risk of suffering consequences that may actually speed up and hasten your death. And
Right,
it's true.
especially if it's done improperly, right? Yeah,
Boom.
exactly.
Internal
So, yeah, so you're saying it should
testosterone.
be a subspecialty done by specific, medical clinicians, exactly.
Medical doctors and healthcare practitioners that have a background in primary care. And
Mhm.
that's why I'm training them. And Andrew's on board because he's an expert working with healthcare physicians in the world from the pharmaceutical. He's a brilliant man. And we're really brothers together, we say in the treehouse, because we compete on vital signs. We love the ABC. Look at them. We compete on vital. We are 20 years ahead. We're biohackers.
100%.
That's
So
it.
let me introduce Andrew. So Andrew, how did you come about to partner up with Dr. O'Connor here and help scale this vision, of testosteronology to like a global network?
Well, it's something that is every day is an absolute blessing to me because I never thought it would actually come to this. I've been in the pharmaceutical industry in the field of commercialization and on the research side for the past about 12 years now. And I've also been, since I was in my early 20s, I've been an enthusiast of, life enhancement therapies such as hormone optimization. And, being in the pharmaceutical industry, always with a specialization in preventative cardiovascular care, I began to piece together, okay, what are the risks associated with all this and how can I negate them? So one blessing that I had was being in the industry, I had access to the absolute latest groundbreaking science in terms of preventative medicine. And I had this at my fingertips. I had access to things that people just didn't have. Okay.
Well, tell us
I
what.
have
Tell
access
us
to
what.
what's
Can
that?
you tell us, or maybe you don't feel comfortable telling us?
No, I can say it. So, one of the things that I would do was I would piece together, like, okay, if you use testosterone and it's going to antagonize the renin-angiotensin system, what can I use? Well, wait a minute, I know how to negate that. I talk about it all day. Okay, so theoretically, if I combine 1 + 1, is it going to equal 2? And what I was always trying to do for years, I was always trying to find a like-minded cardiologist or internal medicine provider that shared that same belief. The problem was I was always unable to find until one day I meet this guy named O'Connor, and I see his YouTube, and when you study this stuff as robustly as I do, all roads will lead to O'Connor, and I'm just like, holy mackerel, this guy exists, and
Right.
I actually, the first time I met him, I had to pay the fee to become a patient. And the first thing I said, he looks at my lever. He's like, "Hey, man, you look good." I'm like, "I know. I don't need any help. But listen,
Right.
you know what I mean?" And then from then on, he started the Ask the Doc Live years ago, and I was a very strong enthusiast. And then we just gradually, our friendship has really evolved over time. And here we are today, and we're really spearheading the testosterology movement. And my roles and responsibility is to bring new testosteronologists on board and make sure that they are being educated properly in the field of testosterology, which is becoming a new subset of medicine. And we're in many different countries right now. We have affiliate providers the patient could reach out to, and they're all been trained by Dr. O'Connor. So, one of my jobs is every single day for like the last 5 years, I talk to Dr. O'Connor. If there's anything latest in the field of medicine, he sees it. Okay.
Well, let's say cardiovascular medicine.
Yeah, for cardiovascular medicine, yes,
Right.
yes,
Right.
So
yeah,
that's like the thing. And Andrew is so, I mean, he's just a freak when it comes to the cardiac. I just
yeah, right.
And if you look at death, doctor, if you just Google how does someone die, it's important that you know.
Arterial, cardiovascular.
Big
So
time. And that's what then and that's what I'm hearing and what I'm excited to talk to you guys about today is the I guess the misrecognition, if that's a word, but just the misunderstanding of all the physiological effects in the human body when it comes to exogenous androgens such as testosterone.
Wow.
And the beautiful framework that you guys created, and you teased a little bit of it, Dr. O'Connor, was the ABCDs and teaching your doctors how to use that framework to take amazing care of, their patients that are doing testosterone optimization therapy and whatnot. So, why don't we jump right into it? Let's start with the A's. So as I understand, it stands for A1C, if I'm correct. So let's get into the blood sugar conversation. So
Well,
why is
let's look.
blood?
If
Go
you
ahead.
don't mind me saying, doctor. So
Of course.
if you, I look, see, remember, I'm an internal medicine doctor. And
Mhm.
I went through, these programs in the Northeast 20 years ago, and you got to understand the training program I was in was just brutalized. I was brutalized, and it made they were making specialists. It really wasn't back then for primary care. It was, or hospitalists. It was to make cardiologists, gastroenterologists, nephrologists, endocrinologists,
Yeah. Organ
right?
specialists.
So right. So internal organs, it's internal medicine. No one, people don't. I didn't know that until I was in med. I was like, oh, that makes sense.
Right.
It's like internal organs. I work from the chin down. Like
Right.
I work in these organs, and then we're specialized to do it. So okay. So when I realized that, I was always scared of having a heart attack when I was taking steroids. I have the right, Andrew. You got the devil. The devil's here. You wake up in the morning, you go brush your teeth, and you're looking in the mirror, and the angel's over here going, "Oh my God, it's a morning. You
At least you know how to get them to make deals together.
you were probably hypertensive overnight. You have some chest pain. You're short of breath. Your heart rate's up. You're massive. You're on steroids." And then the devil
Your face
comes,
is red. Yes.
your face is red. My face is still red, but that's from the sun, and I'm an Irish Jewish guy, so it's like I'm never tan, so it's okay. So in the end, you're like, you wake up, you brush your teeth, and then the devil comes out and goes, "Hey, look, Angel, go to sleeps. Okay, go back to bed. We got this. We need to bench big tonight." And I went on to my med school and residency, and I just lived that way. And I was terrified of having a heart attack. So I went into programs that were heart based in the United States, the top programs to be a cardiologist. And I realized when I was in the program, in the coronary care unit, my first month working 100 hours a week, I was exhausted. And I said, man, I don't know if I can go on for 4 more years of this, plus 3 years of residency. And then I have to do 3 years plus of fellowship, making 40 grand a year. People don't know it. That's cardiology. So I was like, I think I just want to get off the bus as an internal medicine doctor at the end of the 3 years and prevent people from having heart attacks. So I studied everything, and I realized ABCs, what causes heart disease?
Mhm.
Just globally, number one cause of death in the world now.
Mhm.
Number one, that's new. That's not always. It used to be public health issues and infectious disease. It's cardiology now because
Right.
the world is become westernized. We have
Mhm.
obesity, diabetes, and then hypertension and dyslipidemia. So ABC. So you have to look at the ABCDs. Now, hemoglobin A1C stands. It's really nice to remember it. It stands, and so many people, they've done studies. If you go into the streets and you grab a 42-year-old woman or a man who has health insurance, has a good job, they're broadly educated, they're middle social economic, they're not poor, they're not rich. You say, "Hey, what's your A1C?" 90% of it.
Oh, no.
What? I don't even know what it is. That is an alarm. So
Right.
hemoglobin A1C, and you ready for this metric? And you could fact check all. It's fascinating. Now we have very close, if not more than half this country is pre-diabetic, impaired
Wow.
fasting gluten. Oh my Lord. If you
Right.
start look, look, we know that you got to stop eating. You get the memo, stop eating. You got to get the memo, don't have a chip. Don't have those chips. Don't have that. This is again, this is something so complex behaviorally wise, stress, depression. We sit in our butts all day. This is good stuff and bad stuff, right? So you have to go to the gym. You have to stop eating carbs. Come on. So ABCs, hemoglobin A1C, glycemic index. If you get this perfect, doctor, if
Mhm.
you get it perfect from 20s with by hook or by crook, that's a huge piece
Mhm.
that will protect you from ensuing coronary artery disease, stroke, heart attack, heart failure, kidney disease, dementia. It's true.
Mhm.
So I'm just like, by any way you can, keep your hemoglobin A1C good. So did I answer hemoglobin
Yeah.
A1?
So one of the foundational, I guess, biomarkers you want to make sure you're getting on your panels is like fasting blood sugar A1C,
Dude, it's
100%.
so simple.
Yeah, very simple. It's not expensive. It's simple and something that's, obviously mega important despite your, whatever your age is, right? Doesn't
Right.
matter.
Well, young people are becoming diabetic and
Mhm.
pre-diabetic because of obesity. Obviously, it's bad.
Can you speak to, like, when it comes to safe androgen use, like, why is A1C so important specifically for, let's say, men on testosterone?
Well, it's funny that if you look at androgens, testosterone to a spectrum of steroid use, what do androgens do? They build muscle and burn fat. That is phenomenally beneficial for glycemic
Yeah,
problems.
you might see improvements.
What
Yeah,
massive, oh, not might. The
Yeah.
data
Yeah.
it's massive improvements. However, is it worth it to go on steroids and testosterone at 23? So it's like the ABC, the A is only a metric for me in that. Imagine you have a 45-year-old guy who is coming to you and he's starting testosterone because he's tired and he has low T. This is just one out of millions and just in
Mhm.
this country, right? And he's trying to do the best he can with his diet. So when you look at him and he's 45 or 35, I mean, we're not going to talk about young kids in the 20s and anabolic recovery. That's another animal. This is just regular guy. He's
Yep.
30, 40. He's got a little belly. He's a little hypertensive. The A1C is 5.8. And he's like, oh man. And he's going to like go on testosterone. Well, he has a family history of coronary disease, for an example. And then he's got the pre-diet. And you look in this guy, and he's 44. You look in his arteries with a calcium score, which is C, which is imaging. We're going to get into that. You're going to see this guy's got heart disease already. This is
Right.
why Andrew's in my life. And it's like, whoa, this is nothing. Everyone knows it. So when you go and you look at how do you prevent, like it's really like the guy comes to me as a patient. I've been doing it 20 years. I used to be primary care, so I'm a head to toe guy. I have my ABCDs. I start there.
Mhm.
You should start there.
Oh, yeah.
Anyone. So
Absolutely.
it's like and if the guy with testosterone is probably going to help his A1C,
Mhm.
but if he has a high A1C and he's like, Doc, I can't lose enough weight, well, then you need to work on getting your A1C down. We're not going to push medicines, but I
Right.
like the medicines. Try
Yeah.
the diet and exercise. Try berberine. I agree. I'm opening up a supplement company. It's like, hey, I like biotechnology, Andrew and I, but you should use natural things first and don't take drugs unless you need them. But in the end of the day, I'll take a kitchen sink and grind it up and inject it into my butt if it's going to help me live a better, longer life. I don't. They're getting the wrong message. So
Right.
so that's really the hemoglobin A1C, glycemic index, and steroids and testosterone, and then we're not going to go into insulin, bodybuilding and PEDs. We're not on that
Right.
today.
No.
That's extreme.
No, we'll
And
just kinda hit on, your general average guy who's gonna be on testosterone optimization therapy.
you need the
Needs it.
A1C.
Yep.
Just because it's probably not perfect if you're the average American, because I told you half the country is pre-diabetic. And if I'm just gambling and throwing a dart, the guy that's coming in that has low T, one of the main reasons why he has low T is because he's a pre-diabetic, he's maybe diabetic, he's
Yeah.
overweight, he's
Overweight, yeah.
obese, and this is just a whole vicious cycle.
Exactly, and number
And
one
it's probably
cause of low
also
testosterone?
the
Obesity.
testosterone might be able to counteract the increasing calories that a lot of men are using while on testosterone.
Oh, that's a whole nother animal. I mean,
That's a whole other animal. So
if you look at
Yeah.
GLPs, like Ozempic face, I mean, Andrew and I did a video called "Where TRT Meets
it makes
GLP."
GLP.
I
Yeah.
mean, it's like I mean, what amazing combination! But people get upset hearing about all these drugs. So
Sure.
I'm just going to try to keep quiet and do your diet and exercise. Learn about the ABCDs. Don't put the cart before the horse. Really investigate it. And if your doctor doesn't order an A1C, order it yourself online. It
Right.
In most states you don't need. People don't know this. Also, you don't need a doctor's healthcare prescription to order your own labs online anymore.
That's right. Yeah, exactly. So, that's awesome. I think we should move to the Bs then. Um, Thank you for answering that one. So, B standing for blood pressure, right, and cardiac health. So, I know both of you guys have a lot to say on this topic, being your expertise. So,
Well, it's
um,
probably the most important.
and
I mean,
and
it's
it
one of the
by
most
the
important
way,
ones with
most important
using
for sure.
hormones.
Absolutely. Andrew, you brought up a little bit on blood pressure meds before. Why don't you speak to like cardiovascular risks that are most concerning with testosterone use?
So one of the first things we need to understand about testosterone and any kind of androgenic anabolic steroid hormone is that they are going to greatly antagonize the renin-angiotensin aldosterone system. Okay. What that is going to do, that is going to lead to vascular constriction. That's going to lead to a reduced production of nitric oxide within the endothelium. And when this happens, we develop hypertension. Hypertension over time can obviously comes with a significant amount of risks. So, this is why blood pressure is one of the most important things, probably one of the most important things that needs to be modulated for somebody who's going to be optimized by hormones.
And it also, so Andrew's brilliant on that. And, Andrew, I know, is trying to hold himself back from launching off into, the heavy scientific stuff because
Yeah, he knows me too well.
it's just not, we're not in the right,
Yeah. Well, you got to take my stuff.
but I mean, but look, here's the bottom line. When you take, when people are hypertensive, the ABCs are probably equally important when you look across the board. Diabetes and obesity. See, these things you can't tease out from each other. These are all inherently equally imparted. So with diabetes, with obesity comes hypertension. And then when you take testosterone, what if you're overweight and you have low T and you're in a quagmire where you're like, doc, I have low T because I'm overweight. It's a most men have low T when they're middle age or older because of it's metabolic, right?
Mm-hmm.
So the adipose tissue is poisoning the testicles, and there's a whole feedback. It's very complicated. But we know that if you lose weight, you're like, doc, I can't lose weight. Like I can't get to the gym. I'm exhausted. So if you take testosterone on a man who's already overweight, what Andrew said, and has hypertension already at baseline, do you understand? Those are where the dangers are. That's the real life danger. Now that's where, thank God, it's minimal. And we have the Travers trial that showed men that already had heart disease that were being treated for ABCs. They were treated for diabetes and prediabetes. They already had it. They already had hypertension, and they already had cholesterol issues and dyslipidemia, a whole nother animal. And they had a stent or a bypass. They had low T. They enrolled them into the program. They double blinded, and it was prospective forward moving, which is the gold standard. In the end of the 2-year period, there was no difference in outcome with having another event. That's all it says. But all the men that were enrolled already had heart disease, so they were anchored down with this is where they're leaving. And I know the doctors in the trial, and they're very good doctors. They're brilliant. I mean, I'm humbled to be a colleague of some of these men and women because I'm an internist. But they're leaving out a massive detail. Like all the men that were enrolled in the Travers trial, the first and only prospective trial on heart disease going forward, they had heart disease, so they were maximally treated for A, B, and C. So it just proves, Andrew, that if you take care of your ABCDs, you can even have a heart
attack. Be more specific, that was brilliant. All of these men, Dr. Hewitt, were on pharmacological interventions to optimize their cardiovascular
ABC, every single one. They were on metformin or medicines for, again, we're not giving it a blessing. We're just telling you who was enrolled in this. They had a heart attack. They had a stent. They lived. They had a stent and or cabbage bypass surgery, or they were acute coronary guys. Okay, that's it. Or they were very high risk, which means they had massive hypertension, diabetes. They looked bad on paper. They didn't enroll healthy men, but yet they were treated. They were well treated for, after the event, they had 4 ABCs, and they had low T, and they randomized them to gel. I'm telling you, and it's gel. It's not the injections. This is there's going to be hell to pay on this, because I know from my own practice what can happen to men if they're not treated adequately with and this is why it better be testosteronology, because who is an anti-aging doctor is an expert in hypertension like me?
No way.
Again, I'm just being a clown, but it's just you better learn it. So
Well,
in the end, you got to do it yourself. So the blood
and
pressure, you get a demonis, you get blood, like you said, the renin-angiotensin system is very basic, and then you become edematous. You get puffy, bloated, and everyone wants to go to the anti-estrogens. Wrong, wrong.
You're
It's part of
100%
it.
wrong.
It's part of it, but it's like,
right.
hey, I've seen caregivers say to patients, come to me, hey, doc, my doctor or nurse practitioner is giving me anti-estrogens to treat my hypertension because I'm bloated. Holy
Mm,
shit, you should
yeah.
lose your license for that.
So what I'm hearing is that there's a lot of doctors, say primary care physicians, that are hesitant to treat their patients with testosterone therapies if they
Right.
have high blood pressure, if they have
Right.
hypercholesterolemia,
Right.
because they assume like, testosterone is going to increase my patient's risk of a cardiac event. And what you're saying is the
True.
Travers trial proved
Yeah.
that, hey, if these are managed appropriately, there is no increase of cardiac events so long as they're
Doctor,
managed.
hold on, doctor, hold on. We're having
Yeah, you're
fun.
speaking in absolutes.
Hold on. You're speaking our words now. Let's look at it.
Mhm,
Now, there's apples to apples to some degree, but there's a lot of apples and oranges.
mhm,
Right. So ABCDs were at least treated. Most men that go on testosterone, they don't even know what the ABCDs even are. Okay.
sure.
And they're against them because people are against medicines and they really are. And it's sad. And I'm not for I've never taken a dime from pharmacy, and I'm not against pharmaceuticals. Okay.
Mhm,
But I want to stay clean on that. Okay. For
sure.
my own portfolio and for my own soul. I just don't want the money from them because I know people wouldn't trust me. So I have never have a conflict in that. It doesn't mean doctors and healthcare providers that take some money from and they're working and they're doing CMEs and they're doing education. It doesn't mean that they're scumbags. Okay. It doesn't mean
No.
that that they're selling bull. It's just that I don't want to ever be part of that for now. So what we're looking at is men, low T, had a heart event. They took testosterone. Hold on. They took baby doses of gel. There is
Sure.
no way that you're going to convince me or anyone that knows anything about androgens that the topical gel is the same intensity as a goddamn injection.
No, of course not.
Right there, you cannot say that the Travers trial is this holy grail and that
Mhm.
all testosterone is safe. Nope.
Sure.
So there are
Right.
some criticisms to the Travers trial, and there are some limitations.
As do most
Andrew,
studies, of course.
tell us what it is, Andrew, real
Well,
quick.
limitations are going to be that your method of delivery
Mhm.
was not through the traditional injectable form, and you had a very small subset of patients.
It wasn't really, we're not going to go into it really because it's not a small subset. It was a large subset, and it was done by the Cleveland Clinic team, and it was incredibly well done. However, it's not injectable testosterone. Their levels were not that high. Nothing like injections, Andrew. The
Yeah,
injections
no, I mean everything was not really. I wouldn't
so,
consider those
so it's
levels
like so
physiologic.
you could say, hey, if you're gonna mimic that trial and you're gonna stay safe from a cardiovascular standpoint, have a heart attack, get on all the medicines after people that have a heart attack get on. Hold on. And then don't take injections, take baby gel. And then maybe you'll be safe for 2 years. That's all, and they had outcomes in actually there's some hypercoagulable scare, there's atrial fib, and there was renal injury. Now we're not going to go into it. Those did not make significant features and I'm not going to get into that. I don't think it's real, but it's part of the ABCDs because the D stands for iron. I know you're getting to this, doctor, but you have to do this.
Right.
It's all
Yeah.
you cannot tease out anything. You have to do the ABCDs.
Right. So clearly, I mean, blood pressure being really, really important when you're monitoring and managing somebody on testosterone therapy, right? For obvious reasons,
100%.
it's called the silent killer, right? It's a very important, metric of health. So it's
And
one of the
causes
things
erectile
that's
dysfunction. Erectile
right. It's
dysfunction.
like the canary in the coal mine, right? It's one of
Right.
The early signs. So I was going to ask you, what are some of the red flags you look for before we move on to the C's? Like, tell me about red flags when there's, a guy who's approaching you to, potentially get on testosterone therapy. What are some red flags you look for, when it comes to that cardiac or blood pressure
It's very,
health?
it's guys, it's really simple,
Mhm.
but I'm an internist. So when you do a history, the guy comes in, I always do an hour and a half because I just love that. And you really go over them with a fine tooth comb and you just write down A, B, C, D. You do the history with the family history. If the guy says, hey, doc, at 45, my dad had a double bicep, quadruple bypass. I mean, these people are out there. It's common,
Yeah, you
family.
look at family history, it's another thing.
So family history,
Yeah.
so family history you look at. You look at, does he smoke? Is he overweight? You look at his vital signs, and then you just look at his ABCDs. And again, if he's pre-diabetic, that means he may already have plaque in the artery. So you get a calcium, a coronary artery, that's going to be C though. And
Yep.
the blood. So if we're looking just about A and B, you just look at A and B and you look for genetics on that, family history on that. You ask about their diet. Were they obese as a child? Anyone who's obese as a child is going to have potential for have premature coronary artery disease. Just obesity as a child, you're going to have that stress. And there are studies on this. So why wouldn't you just look for that earlier? Look for it's called imaging. You want to get an anatomical diagnosis in the coronary arteries. So many people don't know about the
No, I agree. But one thing is, to your point, atherosclerosis is a process that begins completely at birth. I mean, there's studies that show that if the mother had high cholesterol, that the child also was born with fatty streaks. This is actually
It is true. It is true. But we don't want to scare.
no,
So
yeah, that's a little bit much.
But the academic side is this, and obviously this is all we do. We live, sleep, eat, and crap, the ABCs, right? ABCDs. But it's like, if you look at how about this? The Vietnam War. Vietnam War, there were young men, we lost, I think, 60,000, mainly men, right, in the battlefield. And a lot of the bodies they took back. Here's the truth I heard in med school. In that 1960s and early 70s, we made significant advances medically in coronary artery disease and burns because of the napalm and the burns, right? So we had unbelievable burns from that war. It was just a brutal guerrilla war. And they had advances from Walter Reed and from I taken care of a lot of amazing Department of Defense, heroes that I still have. And I've learned this inside stuff. And then another thing was when they had the bodies, 19-year-old bodies that came back, 19, 20-year-old men, and they did autopsies. They kind of had it's different than it is now, apparently. They did a lot more scientific autopsy on it was the kind of the I mean, really the government saw that they wanted to learn more and they had these bodies. So I don't think they do that now. So they opened up and they looked at the coronary arteries. Andrew said it. 19-year-old men already had coronary artery disease.
Subclinical arterial sclerosis.
I'm telling you, and if you fact check this, anyone who's listening to this, you're going to go, holy shit.
And this is why I said earlier that, look, I just think, okay, the Travers study had 5,200 patients, okay? 2,600 on the therapy, 2,600 not. I would have liked to seen around 10,000, but we'll take what we can get. Dr. O'Connor has the final word. I just think it was a little underpowered in terms of patient population. But
right, you're a big pharmacist. You're a big pharma guy. So right, some trials are 10,000 plus 20. You're right. You are right. But for the average bear, like that was a big trial for testosterone. We've never done any of that before.
Yeah, right.
It was random.
Yeah, that was what was landmark about it. It was the first of its kind.
And the thing is, two things. I like that because I like testosterone. So I'm glad that they did it. I'm like, yes, because it's controversial. And if you do the ABCDs, I've kind of shown that you could do testosterone and even a little more if you want. I mean, but don't do what I'm doing, because I'm very advanced. So, and I'm lucky to some degree too. But I had heart disease and I reversed my heart disease. I reversed it, and that's a whole nother animal, right? But I did it with the ABCDs. But if you really look at it, if you're going to take testosterone, what Andrew says, with great privilege comes responsibility. You need to, you can't just go to some anti-aging place and, hey man, take
Right.
200, take the AI, take the, be bloated, you don't even know your ass from the hole. You need to really, and if you're not ready to do it, sir, don't do it. Lose weight and just suck it up. Because is it worth it it is true, controversial, that if you have unstable plaque in the artery and you're not treated like the Travers trial, and anything that you take increases blood pressure like testosterone, it's guaranteed to cause a bad outcome. No one's going to argue me on that. But the trial didn't look at that. It looked at outcome. It looked at end outcomes that said they had a heart attack or bypass. Did they have another one when they started testosterone? And the answer is, on a randomized double, the answer is no. But it because they were on medicines to prevent. This is what we're trying to drive home.
Right.
Yes.
So for the average listener, Tom, before I move on, does testosterone elevate blood pressure in everybody?
Yeah, no, hold on. You can't globalize.
Well, I'm asking, should everybody be concerned about their blood pressure rising?
That's a great. There we go. Yes.
Hold on. Does every single man have the same size penis?
No. I rephrase. Should every man be concerned that his blood pressure could rise when taking
100%?
Thank you. That's all I wanted to know.
And if you go on 200 milligrams of testosterone from your
the more you take, the higher the risk. Yes,
it's guaranteed. Your blood pressure is, and if it doesn't go up, you're full of shit.
There we go. I love it. So let's move on to cholesterol, right? So the C on lipid health, and another one that's really, really critical. What I want you to share with the listeners is, like, how do androgens affect lipid profile specifically?
Andrew, you're the master at this.
So one of the big things that I've studied many years is lipidology, and oftentimes that we see from when men and women use androgens, we see dyslipidemia. And where we see the LDL, which is the lipodense lipoprotein that is atherosclerotic and causes plaque buildup in the lumen of the arteries, we see that go up, and we see the HDL go down. The hypodense lipoproteins that were always thought to have a protective effect, now we see they really do not. It's maybe a marker of metabolic health, and that goes down. So what we have is now over time, when there's all this LDL cholesterol and ApoB particles are the accumulation of all atherogenic particles, chylomicrons, et cetera, whatever. When they all sit around and fluctuate inside the arterial walls, they bind to the arterial walls and they create narrowing of the arteries. This is the atherosclerotic process, what leads to heart attacks. So that's what, it's.
So let me just pick up, because people, this is true, doctor. No one's going to argue, from the left to the right, from any influencer selling whatever they sell, or who's good or who's bad. No one's arguing obesity and glycemic index, right? Okay.
Right.
Let's go to blood pressure. No one is going to argue that blood pressure. I mean, it would be embarrassing that if, hey man, crank the blood pressure up, guys. Come on, guys, crank the blood pressure up. Fuck having a stroke and a heart attack and heart failure. Come on. Okay. So it's and there's so much data to prove it.
Yep.
B, now cholesterol. Andrew, we're in a tough place on this one because we have some expert lipidologists, right? Like Dr. Nolan, who, here's my take home message.
Dr. Allo. So,
Dr. Allo, these are outstanding cardiology doctors. I mean, now look, here's my take home for the listeners that I've even changed my ways. If you don't have atherosclerosis on imaging, you've never had a heart attack, never had a bypass, never had something called acute coronary syndrome, never had any concern for any vascular damage to your coronary arteries, not to mention peripheral vascular arteries below and your carotids and your brain. So again, welcome to getting older. So if you're just a regular guy and your coronary arteries are clean, where you've checked everything, your family history is otherwise fine, not alarming that in your family history, the ApoB and the LP little a, there's genetic particle. I mean, it's all there. and then you're not just your dad smoked and drank and had a heart attack at 48, but not every man who smokes and drinks a little bit has a heart attack at 48. A lot of people say that's still a risk. If you look at the American College of Cardiology, the early preventive heart disease for men and for women, right? So in 50, they say 60. It's really like, if even around your 60s for a man and a woman, it depends on how you want to see for how early it is. But when you're looking at this and you look at the overall risks for people, cholesterol is tough, because if it's, say, over 100 milligrams per deciliter, it says high. It used to be 129. Some places it still is. But now Andrew and I, we the lower is better, lower is better. The truth is this, and Andrew does agree, but he's very advanced because
I'm about to disagree, but keep going.
Hold on. See, we're going to argue on it. We're going to argue, and because doctors are arguing too, and that's where no one argues A, no one argues B, C. If you don't have heart disease, atherosclerotic heart disease, do you need to shoot for a very low LDL, and is LDL going to hurt you? And that is controversial, in my opinion.
Mhm.
It should be controversial. It's like saying let's keep smoking cigarettes and we'll stop when we get lung cancer.
But so there is some data supporting that it is tricky, because this is fun stuff, right? Not everyone that has high cholesterol is going to have atherosclerotic heart disease, not to mention die from it. We do see some people that they're older and they have this cholesterol, but they don't make plaque. So there's a lot of moving parts. You see, A, B, C.
Well, subclinical arteriosclerosis, sometimes you can't see on a test.
No, I understand. No, again, no, I like to be, when I see someone that has, we worked on the A, we worked on the B, diet, exercise, some nice light supplements. We're using baby doses of our medicines that we love that give better pumps and better erections, and I could bench better, okay? And I'm 60. So, like, you can't argue, and I look like an infant on paper. Like, my vital signs are that of an infant, but it's huge biotech, right? And it's very complicated, and a lot of good supplements. And in the end, when it comes to the C, because of the data from Dr. Nolan, and I know where Andrew's coming from, because he's working right in the modern cardiac guys that I love and I agree with, but I don't know.
Every interventional cardiologist who cuts people's chest open for a living always say get the LDL as low as you can. The sooner the better, and the longer the better.
Okay, now, but I agree. But see, Andrew. Even I'm going more like mainstream. So I'm like, wait a minute now. So
but mainstream has atherosclerosis.
No, but what I'm saying is that there are people that have suboptimal lipids, and that yet they don't have atherosclerosis. And it's like, now, because we're looking at those nasty statins that unfortunately have a very bad rap, but they're just medicines, and they're miracles, and they're cheap. No one's making money on statins anymore. Doctors are trying to push statins to make money. That's an embarrassment for whoever says that, because they don't even know what they're talking. There's no money in stat. Okay, that train has pulled in and out of that station decades ago. They're dirt cheap, pennies. Okay, so statins work. Yes, they have side effects. I don't like taking too much of it, so I use other medicines, right? My PCSK9.
Yep, that's it.
I like to keep because I have heart disease. So here's how I look at it. C, you have heart disease or you don't. You either have heart disease because I had a heart attack, I had a stent, I had a bypass, I had acute coronary syndrome, microvascular. Okay, they said I had a heart attack. Okay, you have you're a whole nother animal now. Now,
right.
Or you are smart, you're young, in your 30s or older, and you checked an anatomical CT scan for $75. It's not a CT angio, it's a coronary artery calcium.
Also a blood test.
It's super cheap. It's the American College of Cardiology, American Heart Association recommend, if you're not sure you should be treated for your cholesterol, you should, again, this is what No one's going to say, oh my God, O'Connor's running amok right now. I'm just telling you the truth. And I don't care if it's UCLA, Cleveland, really good doctors. And your doctor, I'm talking, your doctor should know this. And around 30, if you're not optimal and you have a family history, you're going to get older. Just by being a man is a checkbox for premature heart disease. You're a man, check. You're over 40, check. It's like, whoa, I got 2 checks. The data says that you should keep your LDL low and be on a statin, but I don't know. People don't want to hear it. So
Sure.
you have to, then my question says, is this, I put all the pieces together as a doctor, a caregiver. I look at the calcium scores. You should see, Dr. Hewitt, you should see, I have guys that are 32 years old that already have heart disease with atherosclerosis. It's freaking, it's kind of a gamble.
Well, you just said it's a gamble. So if you were somebody who had LDL that was north of $120, why would you want to take the gamble that some of that's going to stick and you're going to have heart disease?
Because I know that there is a small portion from talking to Dr. Nolan of people that this is not LP little a.
Yeah.
Don't get upset with me.
We're not going to talk about
It's,
it.
it's because I'm not sure, Andrew, because I used to be just really rigid. And I don't want to be a rigid doctor. I'm bad enough with my personality.
No, but you are sure. Because you know why? Because if you could go back in time, I know for a fact you would have your LDL tanked, so you never have any plaque surgery.
I have heart disease. So I'm prone, but I'm pro. So once you have heart disease, even if you have one Aganston unit on the C, which is coronary artery calcium score, everyone listen to that. It's a coronary artery calcium CT scan. It's not a CT angiogram. Don't get the CT angio. But when your doctor or caregiver says you don't need that, and you're 40-something years old, you tell them I'm going to punch them in the teeth, because how many men, hundreds, maybe thousands now, just on the app that have remember the guys, Andrew, we have on the app that have been like, they're like, what's a guy in Miami we love to death? We haven't seen him in a while.
Oh,
this guy was in his late 50s, skinny like a twig, didn't smoke, didn't drink. I mean, he's a Cuban guy, really funny. I love him. And he's like, his cholesterol is a little boom, boom, not even bad. And his doctor's like, you're a tiger. You got the heart of a tiger.
That score was like 800 or something.
900.
Yeah.
The guy comes back to him. That's why he loves us. He $75. He comes back to the doctor and he goes, doctor, shame. And the doctor did beg for forgiveness. I mean,
you know what would have prevented that whole conversation? Aggressive LDL management.
Hold on. So we don't know. There's no crystal ball on really who is exactly, this is going to change in the future, who exactly has atherogenicity with the lipid panel and who doesn't. I mean, Dr. Hewitt, you wanted us on the show, dude.
No, I love it.
So,
well, I mean, there's
Google the PISA trial. Okay. Anyhow.
No, but I think so. Look, I have a talk with people, Andrew, and I really personalize it. And we do the A and the B. And then some people are like, Doc, let me do the metformin and the A and the B and try to lose weight. Let me just try to. But if they have heart disease, evidenced on the calcium score, I am aggressive. And I say, sir, now no one's going to argue. Now you are in the party. You are in our party. You have heart disease. Now, no one at Cleveland Clinic, the best doctors in the world, are not going to, when you have one Aganston unit of atherosclerotic, it's hard plaque. Oh, then it becomes hard plaque and soft plaque. Where there's smoke, there's fire. You have a 0 across everything. That's great. Good for you. But what we see is, to Andrew's support, is you're 32, 0 calcium score, rock on. I've been doing this for 20-something years, right? So I've seen men over time where I say, okay, you're 0, you're 41, you're pretty lucky, right? Your cholesterol is not perfect. Your blood pressure is good, cholesterol, good genetics, no family history. Usually just family history, I could predict a calcium score not being, it's freakish. So if you have premature, and then when I say ABCDs, I ask the patient, sir, what is your appetite for prevention.
Mm.
You see, Andrew, right? So, and most men, I find women too, but I don't take care of women anymore. I just take care of men on androgens. So most men, I find if you educate them, they go back to their wife, they go back to their family, they do a lot of Googling and they go, And then a friend drops dead on the golf course or gets a stent and he goes, Doc, I think I'm ready to just really be, maybe I could be proactive or preventative. And no, A, no one's arguing. B, no one's C, most people will benefit from lipid lowering.
The whole point of preventative therapy, so you never are a patient of Dr. Nolan. You never are a patient of Dr.
I
Allen.
love it.
Yeah,
So
that's the whole point. So you have to have a stent or get one against the urinary tract score. Well, we got to do deposition. We got to do D.
Yeah, well, hold on. Do you recommend a calcium scan for every guy? Let's say over a certain age?
Absolutely.
Okay,
I don't care
good.
who it is. 30,
Before we
30 years
move
old.
on, we didn't talk about HDL. There's clearly HDL lowering that happens with testosterone therapy as well.
Right. Right.
Can you just touch on like when is it too low and what do you
We
do?
don't know. So Andrew, what an amazing point. Andrew brought up some new data. Go to Google, everyone, and really look at new studies, modern studies, HDL protection.
I could bring this up.
Go ahead.
You know, there's been numerous medications that have been out over the years, and numerous medications that have been studied to raise levels of HDL. They have shown actual harmful effects. Actually, years ago, niaspan came out, the AIM High trials. It did not show that high levels of HDL reduced outcomes, improved outcomes. It did not improve death, did not improve risk, because the old dogma was that if you had high LDL, it was okay because it was balanced out by the HDL. This is shown to be completely false.
It's not true. It's not true. So again, the lipid,
Go ahead.
doctor, the lipid pan, I'm going to tell you, there's a study called lipidology. It's a full day job. Does that tell you something? There are doctors and nurse practitioners that spend their whole day only doing lipids. I'm telling you, this is a world that is so specified. So really understanding these lipogenic particles is what Andrew and I look at. And he does it from a pharmaceutical biologic standpoint as an educator. I'm a physician. And I could tell you that you have to put together something for someone who is personalized. Now, say you have a high HDL because you're alcohol. Go to Google, put in.
Yes, ethanol will increase the HDL.
So if you're this is, listen to this little unbelievable. I was a first year resident. We were the workers, right, in the level 1 trauma centers in New York City and Hartford. And we were taking in men and women that were they were severe alcoholics, and they had to drink to stay out of DTs. You've heard of this, right? So when you go into the hospital to recover, it's very deadly to let someone withdraw off of alcohol. More deadly than heroin. Heroin's uncomfortable, but not as deadly as alcohol. Okay, no one's going to argue it. It's true. So what we have to do is we have to give them benzodiazepines or ethanol. We have to intubate them sometimes in the ICU, and we have to medically get them through this period so they don't die. Heart rates go screaming. They're just it's just unreal, delirium tremens. Now, when the chief came in one of the hospitals I was in New York, and he goes, guys, all right. He goes, I want to show you guys something. This is your, and he was respectful. He goes, this is your alcoholic guy who's, you guys are keeping him out of DTs, right? You guys are treating this guy, right? We go, yeah. Well, how are the vital signs? How's your boom, boom, boom? Good. We can't wake him up yet, Chief. We got him snowed, on the drugs. We're watching him. He goes, hey, run a lipid panel on him. Run a lipid panel. And we go, all right, let's run a lipid. So we ran a lipid panel that night. The next morning, the chief comes in and he goes, let's see, how's that guy's HDL? His HDL was over 100.
Wow.
Done.
Yeah.
So, I mean, HDLs, if you're a booze hound, if like, hey, my HDL's great, it's like, no, you're gonna. So that's a very important piece. And now the studies have shown the niaspan, the niacin, HDL goes up, but there's no prevention on the outset. I'm telling you, you could Google, you could hate it, you could get mad at me, but it's So now women have protection on it because they're also women, and women have protection certainly before they're in menopause. Then after menopause, women become more risky like men, but they still are protected versus men, because if you go to an old folks home, mainly women, men are dead because men just die earlier. Now, I know it's not fully true because women have robust hearts. They suffer with heart failure because they just don't die. I've taken care of them.
Okay.
But this is, I'm not disparaging women, that women should have heart attack, but women have better hearts than men. Why wouldn't you, if you're going on testosterone, man, why wouldn't you put all the resources into your heart?
Right. So obviously
I mean,
there's
we
no
have other
there's no
organs
benefit.
too.
Obviously there's no benefit for pharmacologically increasing HDL. However,
No,
what
no.
about aerobic exercise, for example? I mean,
Excellent.
clearly there's
Absolutely.
benefit. I mean, will you tell someone, "Hey, I'm seeing your HDL being suppressed from testosterone. Why don't you step up
Lose
the
weight.
cardio?" Is it
Right.
lose weight?
Quit
Yeah.
smoking. Quit smoke.
Yeah.
So you want to get the now. This is not that, as Andrew said. Is it a surrogate marker? Is it causation? We don't know. No, it's
Mm.
when you exercise and you lose weight and you quit smoking, the HDL goes up. But how much other important things are happening to you that's protective?
Oh, a whole ton, yeah.
Right.
Tons of them. So let's move to the deposition disease, the D. And I think this one is one of the most fascinating because I think it's the most misunderstood, or the one that's not understood by a lot of whether it's
Oh,
doctors or
misunderstood
patients or
and not
whatnot.
understood.
Yeah,
Right.
exactly. So can you speak to the deposition part of
Let
the
me try to
ABC?
do this because so far the listeners are still hanging with us. No one's going to argue, and anyone in primary care, nurse practitioner, anyone, and even who's a student of it or a doc, no one's going to argue A, B, C. And C stands also for cholesterol, coronary artery calcium score, echocardiography, echo, ECHO. So I get all these things done. I do like executive physical for my men. That's just what I do. And I'm trying to change the metric and standard of care for all men and women that are on testosterone. I want them to have the highest standard of care, which is going to be the ABCD implementation by a testosteronologist. So D, D nicely stood out for me. When men and women take androgens, every single one has some degree of what's called androgen induced erythrocytosis. I'm going to say it again, AIE. And this is a subset of hematology. It's not endocrinology. It's not cardiology. It's hematology, but it's all internal medicine. It's what I am. I'm internal medicine.
I think this is where he truly shines is when you talk about the
Right. The D,
hematology
I own
aspect.
the D. I've worked up the D for 20 years with the smartest and most experienced hematology doctors, initially in the Northeast, because I took care of steroid users and I was like, holy shit. And I made all them go to specialists and specialists. And I was starting to, look at the notes, call the doctor. That's all. I was a concierge doctor, like I still am. So I get to call and track things down and chaperone the patient. I actually did go to one guy to his doctor, and the doctor had so no more respect. He's like, Doc, can you go to the office visit with me? And he was some very wealthy old doctor. And I go, I'll go to the visit with you. It's right down the road. And the doctor looked at me like, you are a scum. Like, you have time to be in the visit with this guy. So I was like, I'm not doing this one ever again. Maybe I'll just call the doctor. Okay. So that's just competitive stuff, right? So when you look for men more commonly versus women that are on androgens and bigger doses and injections, not to mention nandrolone and deca, stuff we love, right? And other drugs, even anavar, all these different drugs, you start getting a condition that called AIE. Other doctors and healthcare providers call it polycythemia. And let me show you why, let me explain why it's wrong. Polycythemia is a Latin term for many red blood cells, which is really kind of technically a semantic, and it's true. But polycythemia really relates to a condition called polycythemia vera. And if you Google that, that's a bone marrow malignancy, cancer in the bone marrow. And when you have, it's rare, and it's typically someone who's older than 60. We're looking at guys in their 30s and 20s on steroids. So I started to realize that the polycythemia is, they're taking an apple and they're making it into an orange when we have AIE, but looks similar because when you take androgens, if you look at the CBC, there's only 3 things on there: white blood cells, red blood cells, and platelets. That's it. And there's a differential. If you order the differential, it breaks down the WBCs, neutrophils, basophils, okay. But when you take androgens, there's an isolated effect only on the red blood cell line. It doesn't affect the WBCs, and it's very rare that it ever affects the platelet line. Very rare. I've been doing this 20-something years, over 10,000 patients. I never see the platelets affect. If the platelets are affected, you got something else going on. Thrombocytosis, thrombocytopenia, that's a whole nother animal. Again, back into internal medicine. Okay, so we're looking at, and when you look at polycythemia vera, it affects the platelets. And there is hypercoagulable state. They can have blood clots. We do give the aspirin. It is a malignancy. You have hypercoagulable. Again, this is where the whole thing went wrong, where when men and women started using more androgens into the 90s and turn of the century, and we saw that more and more and more, they adopted the inappropriate adoption of polycythemia vera diagnosis and outcomes potentially, and they put it on androgen-induced erythrocytosis. Thank God. And we have the only studies we have, if you look at JAMA, if you look at, are men at risk for a blood clot, it's called venous thromboembolism, or it's a DVT or pulmonary embolism, not stroke, not heart attack. Now we're in the vein system. This is why, guys, how can you have to be an internist I'm sorry. You have to be. I mean, come on. It's cringy.
And that's what kills more people in an acute setting.
Right. So in the hospital setting, when you work in there like I did for over 20 years, you know what DVT prophylaxis is. You know what DVTs, pulmonary embolisms, okay? You know them. I've had people die in front of me. We've coded how many thousands of patients on my training years from pulmonary embolism, right? Because they're sick, they're in the hospital. Okay. So when you look at the relation, does androgen cause this? The answer is, thank God, no. It's tricky. But then you look at the thick blood. Does that thick blood lead to an increase in?
That's what I'm thinking. Yeah.
Hold on. There's a few studies that show it may. Here's the bottom line. It's not a clean study. I forgot what it's in JAMA. There's 2 studies. I just don't have it on top of my head. You can put JAMA, modern study, which means the last couple of years, Journal of American Medical Association, testosterone, and blood clots, DVTs. They have a statement on it, and it said within the first 6 months to a year, if a man, again, it's more men because now we have more women too, but we're just looking at men for TRT, not steroids. You're going to see a potential increase in the incidence of having a DVT in the short term. Once you're past that initial year, there's baseline. There's no evidence to indicate that there's increased risk. I'm done. Again,
so it seems like it would be a patient who had factor 5 or
right.
Okay.
What? So if you look for underlying hypercoagulable states,
exactly.
if you're factor 5 von Linden,
yep,
protein CNS, GP. There's 2 or 3 others. Again, I don't do this every day because I don't do the internal medicine. This is hematology now, guys, and pulmonology. Okay, you have to be humble for internal medicine. So when you put it on testosterone and steroids, what happens? Your red blood cells go up. Does that lead to an increase in outcome for having blood clots? And the answer is No, I don't think so. Because, and what's the cutoff? Where do you keep your H and H and your iron studies? And forgive me, this is what I do all day, so it's fascinating. Again, personal fingerprint. The guy has heart attack or a stroke or heart failure. I'm taking a new guy with heart failure, Andrew. Wait till I tell you this case from yesterday. Young guy. He had cardiomyopathy from too much thyroid medication. Very rare. Very rare. Very bizarre. It's a man. Yeah.
Young too, you said?
42. Yeah, young, 42. No steroids.
Okay.
So it's an idiopath. It's a very complex. I'm taking him in. He's on testosterone, and they want to stop everything. And I'm like, whoa. So
we'll talk about that later.
I'm going to work with them. So when you look at the hypercoagulable state related to the androgen-induced erythrocytosis, don't say polycythemia. Say erythrocytosis. Say it. Say the right word.
Erythrocytosis. We got it.
Say it. Don't say polycythemia. Irritates
Doc,
me.
just for the listeners to keep it very clear, the D stands for deposition disease, right?
So listen to this.
Hang on. So what are they looking for on blood work
It's
that's
very
specifically indicating deposition disease?
So the D is a mnemonic that it was, remember, ABCD.
Yep.
Everyone is going to have some increase in the red blood cells. If you think I'm wrong, man, look at not everyone has problems with it. And I'm going to review that now. If you look at your baseline from a guy who starts testosterone, and then 6 months later, for sure, look at your CBC, you're going to see it's up a little bit. And I'm guaranteeing that's almost I mean, of course, the guy's bleeding. He has a cancer. I mean, he has a huge trauma and he has some surgery beyond that. So when you look at this, you have the metric where the doctor or nurses are looking at CBC. The upper limit normal on the reference range goes to 18 and 54. But however, some places, some facilities use 16.8 or 17. And if you're 17.1, it says high. And the doctor who doesn't know what to do says stop testosterone or phlebotomize. Now, in addition to the CBC, looking at the red blood cell line, you need to look at the ferritin and the iron studies. And that stands for the D for iron deposition disease. But most men, so say you're a Caucasian man from us guys, right, from Northern Europe, well, more me and Dr. Hewitt, right? DeCaro, you're more a Mediterranean lover, right? You're a Latin lover from Mediterranean, right? So, and you have.
I don't know about Latin, but, Italian.
You're Italian, but what do you, listen to this. What do you have?
Italian from area.
What do you have? What kind of red blood cell issue do you have?
Oh, thalassemia.
Hold on. He's a Latin lover. I'm sorry. You're a Mediterranean lover. I do apologize. You have a thalassemia. You never have a problem with the red blood cells. I'm in Northern, me and Ryan and I, if I'm just gambling, and I'm not a racist, I promise. I'm not profiling. Hopefully I'm not profiling too much here. So if I'm gambling, we have genes that you don't. And when we go on testosterone, those red blood cells are not only going up, but your iron can go up.
Yeah.
But for most, it doesn't. It goes down for two reasons. Number one, and this is why when I see this, I think, sir, have you had a colonoscopy? Then I go, the guy's 52. He's like, I've never had a colonoscopy, but he makes money and he's got insurance. And I'm like, sir, can you get a colonoscopy? Maybe he has a polyp and he's bleeding from the GI tract. Again, internal medicine. So when you look at this, some men, a small subset of men, it's like 1%, maybe 3%, Caucasian men from Northern Europe have genes for hereditary hemochromatosis. There's, I think, 5 genes, maybe 7. And there's 3 common one or 2 common. And when you see the carrying state, and it's the homozygote is both too, right? That's hereditary hemochromatosis. I have those patients. They find out the hard way because they have a stroke or a heart attack, or they have deposited iron into their liver. Mm-hmm. And so that's hereditary hemochromatosis. And if you do steroids, I have them, very rare. You're screwed. So
Right.
you have to phlebotomize like medically. So I have a few rare cases and I've done videos on them and it's fascinating. But if you're the average bear and you have a partial gene and you're like, man, my ferritin's like 600 or 400 or 1200, I've seen 1700, that
Wow.
you're going to die. And
Right.
androgens are exacerbating it because they exacerbate the metabolism from how iron comes into the GI tract and enters not just into a red blood cell moiety with erythropoietin, hepcidin, with the liver and the kidney, but the bone marrow, but it also works when you have too much storage, completely silent. You're going to deposit it over time in your brain, your heart, and your liver.
Wow. Yeah. So you're watching your CBC clearly, the red blood cell, your hematocrit, your hemoglobin, and then also the ferritin levels and the
That's it.
serum iron. Yeah.
Done.
Got it. So the last in the mnemonic is screening. So S. So can you talk about what screenings in particular are you looking at
Very
when you're
simple.
working with guys on testosterone?
Very simple. And thank you, whoever who's left and not thinking I'm the most crazy person in the world. It's just what I do.
Too late.
Okay. So
Too late.
it's for the 4 men that are left. Okay. I love you guys. We got 4 new guys.
Don't worry, we'll edit it. I'm just kidding.
So here's the deal. So screening, right? So ABCDs covers everything. Screening, head to toe. You ready for that? Head screening. When I think, because I'm a primary care doctor, mental health screening. So screening. Then I come down and I go, oh, skin. Oh, skin screening, skin cancer screening. Okay. And then I keep moving down. And I don't know, you can get thyroid, get a thyroid, look at the thyroid, look at TSH. Someone should do. With all the Zoom stuff going on, I tell people, I warn them, I can't put my finger in your rear end and I can't touch your neck and I can't feel. And when I was a doctor in person with people before I was the internet doctor like this and stuff, I told people that I don't feel comfortable checking the thyroid for nodules for cancer because my fingers were not. I'm like, I'm so respectful. How do those doctors feel those tiny little pea-shaped nodule? So physical exam. Now, when I'm in the neck, I also think of heartburn. People that I have heartburn and I have pre-cancer called Barrett's. Dude, I had it and I reversed it. So if you have heartburn, you need an upper endoscopy, guys. Again, this is common. If you're taking a proton pump inhibitor or Tums or Zantac and you're just masking it and you've never had an upper endoscopy, your insurance is going to pay for it. Your doctor is overwhelmed. They should be asking this. Now, let's keep going down. Heart. I did the heart. Did I do the heart? ABCDs. I did the heart. Can I keep going down? Oh, next to the heart, we have nipples, gynecomastia. So there's 2 types of gynecomastia. And that's screening because I've seen 2 or 3 patients with breast cancer. I've seen 2 or 3 patients that are men with breast cancer. Men do get breast cancer.
Mhm.
Now, with the grace of God, anabolic steroids not only do we know that they don't cause breast cancer, they were designed to treat breast cancer. Masteron.
No, yeah, that's right.
They were designed to treat. Again, go to Google. This crazy O'Connor, going to check him again, fact check me one more time. Masteron, steroids, 1950s, DHT, nandrolone derived, even testosterone derived. They were produced for aggressive metastatic breast cancer because they act like tamoxifen. Okay. They compete and they block. Okay. You can check it. We don't use it anymore because we have other drugs and we have other experts that are involved. I don't do breast cancer.
Oh no, Masteron is still used today, but yeah. Anyways,
It was marketed for this in the 1950s and 60s. People have no idea. So gynecomastia is literally bitch tits, and it's such a focus for men, that estrogen. And when you come to that, it's like, do you have a nodule? And if you have a nodule or a lump or a bump or a mass, I have to think breast cancer until proven otherwise because I'm an internist. So I make people, men, believe it or not, they do a mammo, they do an ultrasound, and they may even biopsy. So a very good surgeon, those are surgeons. Those are breast experts, surgeons, general surgeons. or breast surgeons. They're surgeons. They're not medical experts. They're surgical, but they're the ones that doctors like me, if we have a woman or a man that we have a breast mass, boom, I don't mess around. And now no one has access to any of this shit. You're doing it yourself. And the walk-in clinic, you got to give them a break. They're not trained like this. So let's keep going. We're out of the tits. We're out of the heart. Go down the belly. Anabolic steroids cause liver and kidney disease, but we're not talking about that today. Testosterone doesn't cause direct hepatotoxicity, and it doesn't cause cancer, kidney disease. But if you're hypertensive, imagine this rabbit hole. Here we go. We're going to go rabbit hole. You're on steroids, testosterone. It's not toxic to the kidney directly, potentially, trend may be, but you're on testosterone. You're hypertensive as a banshee, and therefore the hypertension secondarily destroys your kidney. Aha!
Renal arteries in the kidney. Just like you have arteries by your heart, you have renal arteries, cerebral arteries.
Right. You're destroying your brain, your kidneys, and your heart. This is Andrew. This is my life. I mean, I don't understand why people don't get it. So let's keep going down. So the kidney and the heart, I did all the internal medicine, the spleen and the organs and all this. We already did ABCDs. Now we're into the pelvis. Pelvis. You have testicles. Well, your testicles are going to be shut off. I deal with a lot of guys who were trying to work out deals where we can cut deals. We can be fertile. We can maintain some fertility. Please, I don't want to go into that. Imagine me going into this right now. It's going to be 4 more hours. So we have the testicles. You could feel them. You could check them. You can get an ultrasound. If you have a mass, testicle cancer is typically young men. There's an uptick in testicular cancer with older men, probably because of obesity and just fertilizers and horrible shit in our food. I don't even know. I mean, hopefully RFK is going to work on all this kind of dyes and the shit in the system. So now prostate, this is the PSA, right? Screening,
yes,
colon cancer, colonoscopies, guys. We're down to at the balls and the anus. There's an uptick in colorectal cancer. I had a guy last week. His wife, he's my patient, so I hammer on him. His wife is a nurse. She's retired. She's in her early 60s. They're crying on the phone to me. What's going on, man? It was, I don't want to even say her name. She just diagnosed with advanced rectal cancer, doctor. And I said, didn't she ever go for a colonoscopy? No, she didn't believe in it. It's sad. They're going to have to. They're going to put her. She's going to be. Her whole rear end's going to be opened up and cut. She's going to have a colostomy bag for life, probably.
Yeah. Testosterone therapy or not, good idea to get one of those.
I mean, I'm just telling you, ABCDs. Now I'm down with the anus and the testicles, and then you go back to the top. What have we missed?
Yeah, not much. I mean, you got your extremities.
I got a question. Could somebody get an MRI of the pelvis in replace of a colonoscopy?
No, they have a virtual colonoscopy that's a CT scan. It's a good question, and it's not really you. They developed that many years ago, and the problem with that is it doesn't detect as well with the specificity. They could miss things, and then at the end of the day, if they see anything, you're going for the colonoscopy anyway, son.
Yeah, fair enough. Yeah.
So I will say this though, because I still read 24/7 on primary care. So Cologuard, if it's someone, oh, by the way, everyone needs colonoscopies at 45. It's not 50 anymore. It's 45. And if your insurance doesn't pay for it, threaten to sue them.
It's true. It's true.
It works all the time for me.
Yeah.
So, Doc, I super appreciate both of your time. I don't want to keep you too much longer. I just have a couple of questions. I know there's so many guys that are on testosterone and they want to take better care of themselves and whatnot. So I want to know your opinion on like how often are you prescribing anti-aromatizing meds, like anastrozole?
I hate the but I've been doing this 20 years. Really, there's no one really been around as long as me. I think you can get around. I think you can get around using at least sparing doses of AIs. And we're talking there's 2 different types of anti-estrogens. There's the aromatase inhibitors, which there's about 3 or 4 of those. And then there's selective estrogen receptor modulators, which are really, that's tamoxifen, Nolvadex. right? And there's raloxifene. Funny enough, this is for breast cancer, for women mainly, and for osteoporosis. But I will use some of these drugs in a tricky fashion for men that are pretty advanced, bro science guys, and they know that they have transient sensational gynecomastia. That's where it burns, but if you microdose testosterone, doctor, if you really microdose testosterone, that takes care of most of the issues with managing estrogen for most men. But if you need a little bit of anastrozole, I like to give like sparing doses. Like, unfortunately, I think the clinics are, they're getting the memo. I'm out there so long now, and everyone loving or hating me, they've seen the message of like, there's no data to support giving 200 milligrams of testosterone to every Tom, Dick, and Harry. Right. Give 2 milligrams a week of anastrozole or more. Crush the guy. But this is what the clinics, the big T clinics. I mean, shame on you guys if you're doing that. Don't do it. Check the heart. Copy me. Go ahead and maybe you can be a testosteronologist. We're ready to train you if you're good. So it's like anastrozole, estrogen is much more beneficial for men. There's no real studies on this, Dr. Hewitt. We don't have studies on it.
Right.
I think it's just everybody's knee-jerk reaction is you're on testosterone, you gotta get on the AI. It's just a knee-jerk reaction.
No one, but this is 10 years ago, 10, 20 years ago when the clinics were getting big, especially Florida, Nevada and stuff. This is not new. And they're just bigger than ever now. Everyone's in it. But it's like, don't start with an AI, man. And look at your ultra sensitive estradiol. Don't look at total estrogen. I've talked to the PhD scientist at both Quest and LabCorp, and I've actually got into a fight with one of them.
Yeah, I was about to say they must love you over there.
Oh, the guy's thinking we should call the state on you, doctor. And I was like, fuck off. the state already's been through me. Okay. Yeah. What state you want to talk about, pal? So it's like, I'm asking you a question, doctor. Why is the total estrogen on your lab with the liquid chromatography versus the ultra sensitive? What's the difference? And after we took the gloves off, I got answers. It's contaminated by other constituents. Again, this is real science. This is real technology. It is interesting. So if you're looking at that total, I used to run total estrogens, and I was like, I've learned, this is about 10 years ago. I've been doing it 20 years. And it's like 10 years ago, I was like, shit, I got to stop copying these guys in the streets and kind of start thinking for myself.
Yeah, no doubt. I mean, it sounds like there's still lots of work to do. I guess one of my last questions for you, Doc, is what's one thing you wish more men knew before starting androgens?
Bottom line, what a question, Doc.
Yeah, great question.
It's going to be a lot of work. You're going to be on testosterone forever.
Done.
I had a patient today that I've had for probably 7 or 8 years, maybe because it was right before the pandemic. And I talked to him today, and I haven't talked to him for like 9 months. And I knew my office always checks in with guys like, hey, got to go for your labs. O'Connor is going to fire you. Like, this is my practice, right? I run it pretty tough. But my patients love me, and I have a great team. And I talked to the guy today, and he goes, Doc, I've been hiding out because, and he's only in his 30s. He goes, I came off testosterone. I used some of your HCG and clomiphene to get fertile for a while. He goes, in the first 3 or 4 months after being on it, I was so nasty and gnarly. My wife and I started fighting, and she was like, I ain't having a kid with you.
Yeah. Wow.
So then listen to this. This is a true story. And then he gets off testosterone. They're still together for 6 months or more. He goes, God damn it. Why, these are men will whip themselves. He said, why did I do this to myself? So I'm going to come back. I'm going to get off testosterone, and I'm going to come back. Fuck it. And I looked at his testosterone today after 6 months because he finally came back. He said, I need to talk to the doc and get my labs checked. He knew he just had to come off and wait and wait and wait and wait. And his testosterone's in the 250s. Yeesh. And he's 30 something, right? And his erections are horrible. He's like, I don't have a problem anymore with getting fertile because I can't even get my penis into her vagina. So
what's worse?
He goes, "No, I'm real. This is real." So he said, "Doc, you told me years ago I did a little of this, I did a little of that. I couldn't wait to have you as my doctor to put me on testosterone." He was 28. I don't know what he was, 20. I don't know. He wasn't a baby, but he wasn't old. He was like, and his testosterone's all over the place because he's using it. He's off, he's on, he's steroid guy. But he's not a big, he's not a fucking he's not a pro. He's just a regular guy. Millions upon millions upon millions of these guys right now, and more
Right.
every day. And he goes, Doc, it echoed in me for months. You told me after all my ABCDs, you said one thing: you're going to be on this forever.
Mhm.
And I didn't really care and think about it. So that's your answer. If you're a young man and you're going to, I've been on it for 35 years. I've had regrets. I've regretted it. I mean, I've become the anabolic doc, so it's like not bad for a business, I guess, but I've had regrets. Yeah, over my time. I've had problems having children. I had to go to the streets to have my last child. He's 19 years old today. Uh, well, not a few months ago. He's a 19-year-old boy. And the first kid I was able to come on and off. And I just, winged it and just like, there it is. And I was lucky. And then my second kid, we had a miscarriage and I was back on testosterone and steroids. I tested DECA, getting ready to bench, I want to bench near 600. I did in the gym, but I never did in competition. And I remember she had a miscarriage. I was on call at 3 a.m. up at UConn, and she called me. I saw my pager. Oh my God, my wife's paging me. She didn't even call my cell. I didn't have my cell on me. It was up in the call room. And what's going on, honey? And she's just bucket of tears, just had a bloody miscarriage. Had a bloody and she was like 12 weeks in. I don't know. And I was already back on testosterone and steroids.
Right.
And I was like, yeah. I go, don't worry. Do you want me to come home? She goes, no, stay in the hospital. I'll see you tomorrow morning. So I come home in the morning, give her a hug. I kind of blacked out what happened after that, but I went right. I go, are we gonna keep going? She goes, I'm gonna divorce you if we don't keep going. I go, okay. She goes, I want a kid out of you because I had a kid with another woman and I haven't had a kid with her. I'm good for breeding, right? I'm a good breeder. I just gotta make it. So I go, shit.
So say, oh, sorry, go ahead.
No, so I said, shit, I need to go to a doctor. And I go, I ain't going to one of my doctors. I ain't telling these guys.
Why don't you just look in the mirror?
So I was a first year resident, and I'm not prescribing myself controlled drugs, Andrew. You lose your license for that.
Yeah.
Mhm.
So I went to the gym and I talked to my boys in, I don't even want to say the gym. It's underground gym, a lot of cops. And they go, Doc, is this fascinating story? Hey, doctor, don't worry about it. And they gave me Proviron and HCG. And you know what? Within 2 months, he was born 10, 11 months later. She was pregnant like that. And then we made it through the pregnancy. And I said, well, I'm going to stay on the fertility medicines. And I'm not going to come off until she's into the second trimester. That's when I started to kind of learn that, with my patients. Like, don't just run in when you get the snapshot of the pregnancy tester and she stands like this and you go right by her, give her a quick peck in the lips, and you run to the bathroom to inject testosterone. Because if she has a miscarriage, you're going to get shut down again. You're going to get shut down. So, but it's real. It's hard. If you're on testosterone and you're young, it's hard.
Yeah, we didn't even touch on that, how it affects fertility, of course. But needless to say, something you really want to think long and hard about and manage correctly with, your healthcare provider, and something you want to stave off as long as possible. It's kind of the message I'm
It's
getting from you
common
there.
sense. As soon as you start, you're probably going to love it. And then sooner or later, after about 6 months or a year of a trial, I've developed this with, and other doctors have developed that. Like, hey, let's do a trial. You're not going to get shut down overnight. What's the point that you're shut down? That's probably another good question, people. If you've never done if you're a steroid guy and you've been on it for 5 or 10 years, you're blasting and cruising, and you're just keeping yourself sustained on underground test. You come into you cross my threshold and you give me a hug. You're the easiest patient. I have to take you. And then I have to provide you with the ABCDs. If you're not sure you're going to go on, and you're going to try clomiphene or enclomiphene. We have oral testosterone. It's like, I don't know, do it for a year. Don't take much. And if you get a crystal ball and you feel at the end of the year, I love it, then you're done. Then don't have a heart attack.
Yeah.
Done.
Stay healthy. So Dr. O and Andrew, where can listeners find you?
Go ahead, Andrew.
Well, so all listeners can, if they want to learn more and to find us, it'd be going on to testosterology.com, and we have a group forum where they can sign up in group forum where members can go and they could ask questions. They can connect with a licensed testosteronologist who works under Dr. O'Connor, and they can begin their journey.
Thank you, Andrew. And thank you so much, Dr. Hewitt. Maybe you'll break it into a few parts. I don't know. It's so long, but
Sure.
I
Well,
found it
Dr. O,
really
where can people find you? I know you got some active social media channels. Where can people
Right.
find you, Dr. O?
So testosteronology is my number one project right now in the world, testosteronology.com. It's all I own. I created it 10 years ago. Now I'm scaling myself with great healthcare providers. We do have a provider list where you can get your own testosteronologist. It's not a joke. They're trained under me, right, as best we can. They're very good providers. And then on the app, if you want to be a member, you have access to the ABCD portal. And then there's a form. There's Ask the Doc meetings with me. And then soon we're going to have other providers pick up and grow that on their own through the portal. And
I should have mentioned the Ask the Doc live. Right. That's where members can really get on there. If they have a question, they actually have access to him. So
yeah. Again, it's not. We have under 1,000 members right now, so we're not that big, and I'm humble for that. It's taken a few years. Nothing starts big overnight, but we have a lot. We have a lot of men that we're helping, and we will take women, but it's kind of weird. It's for men and women. I felt pressure to do that because there's just so many women that are on androgens, and apart from from the pelvis and the breasts, and there's some differences. It's just ABCDs for women and men. It's sad. I mean, it's not hard to understand the differences. So women, I want to include women because a lot of women are on, especially those perimenopausal women that are. This is being on a little testosterone, Dr. Hewitt, as you know, it's just life, dude. This is, and of course, women. But you better understand the red blood cell, the ABCDs. Even if you're a woman, why? Of course, women have the same diseases. We're humans. So that's it. And I also have the Anabolic Doc channel on YouTube. That's big. It's really advanced, cool content from steroids to testosterone. We have YouTube. We have Dr. Thomas O'Connor. It's on Instagram. We have a TikTok channel, Anabolic Doc. My brother's running that. That's cranking, and we are growing this to get bigger and bigger and bigger in the world. And having you on board, Dr. Hewitt, amazing. We have providers that are incredible all over, allied healthcare providers, right? That we have. We even had some dentists. Now, I thought that was kind of, chiropractors, absolutely, because they're in the wellness field. But we had a dentist, and I was like, dude, you could do the dentistry and learn as much, but
sure.
I don't know if anyone's going to be like, come to get your teeth and a shot.
It's
a little different. Yeah. Well, I really appreciate your time, gentlemen. Huge thank you for being here today and dropping truth bombs as always. And if you found value in this, guys, please leave us a review, share this episode with someone who needs to hear it. And I'll drop all of that info, you guys, in the show notes. So
thank you.
Listeners, stay weaponized.
Thanks, Andrew.
See ya.